Assalamu alaikum. I'm Dr. Abdurrahman Muhammad Alam. Welcome to today's cataract surgery insight into a Morgagnian cataract. First, apply ocular preparation of povidone iodine solution over the eye before cataract surgery. This will greatly reduce the chances of endophthalmitis. Then wash out the povidone iodine with BSS. Now make a side port by stabilizing the eye with a cotton bud. Now apply Blurex and stain the anterior capsule. In white cataract, staining of the anterior capsule should be done for 30 seconds. You want a good stain of the anterior capsule, which will help in visualization of the anterior capsule during capsulorhexis creation. Now wash out the trypan blue with BSS. Still there is some BSS trapped behind the iris. Now still wash it out. The conjunctiva was involved during the side port creation, which will lead to chemosis. Later I will cut the conjunctiva at the side port so that chemosis does not occur. Now I am creating a cystitome by bending a 26 gauge needle. Now increase the zoom and with the help of a forceps stabilize the eye and create the main port with a 2.4 keratome. Now form the AC again with OVD. Also put OVD over the cornea. By placing OVD over the cornea won't dry out and the visualization won't be hampered. Since it was a Morgagnian cataract, with initial incision, a gush of liquefied cortex filled the anterior chamber and it spontaneously decompressed the interlenticular pressure. In Morgagnian cataract, there is liquefied cortex and a dense nucleus. This dense nucleus is mobile and does not provide any support during capsulorhexis if done with a cystitome. So I have decided to use a forceps which will help me in creating the capsulorhexis. Slowly I am guiding the capsulorhexis flap in a circular manner and completing the CCC. Sometimes I am giving gel to form the AC and flatten the anterior capsule. Thereby I can create a beautiful continuous curvilinear capsulorhexis of 5 mm. Now I am washing out the liquefied cortex with BSS. Before entering the eye with the phaco handpiece, I'll cut the conjunctiva near the side port because the side port incision was given behind the limbus that can cause chemosis. To prevent chemosis, I have cut the conjunctiva. Now I have introduced the phaco handpiece inside the eye. With the help of a Sinski, I'll try to chop this nucleus. A small groove is made in the center. Since the nucleus is mobile, I decided to do direct horizontal chop, but I was unable. The nucleus was rotating because there was no support due to the absence of the cortex and the epinuclear shell. I was unable to chop with the Sinski, so I decided to use a sharp chopper to perform vertical chop. Now my assistant is getting the sharp chopper. Now I am using a titanium tipped sharp chopper. Yes, it has chopped, but complete separation has not occurred. There is a leathery posterior plate which is refused to crack. And through the side port, iris has also prolapsed. I come out and the iris goes back to its normal position. Now again I perform vertical chop with that small Sinski. Now I am able to chop it slowly and slowly. I am performing vertical chop and creating multiple small chop pieces. Sometimes I go from the equator and perform horizontal chop, but due to the sticky posterior plate it is difficult to chop, but I managed somehow. Again I'm trying to chop, but this mobile nucleus is not behaving properly and the posterior plate is also refuses to chop. Now I decided to perform phacoemulsification and remove the quadrants. Now inject viscot followed by HPMC to form a shop cell technique for removal of the remaining chopped pieces by phacoemulsification. Yes, all the pieces are being emulsified slowly. Only one piece remained. Now I decide to change the Sinski and use a spatula. I place the spatula in a safe position and guard the posterior capsule from the tip of the phaco handpiece. I don't want the posterior capsule to be aspirated and cause a PC tear. So I'm keeping the spatula above the posterior capsule and below the phaco tip. Thereby the posterior PCT will not occur. Now I refill the anterior chamber with OVD. Now I'll make preparation to remove the cortex. Since the cataract was a Morgagnian cataract, all the cortex has been liquefied and there is few sticky lens fibers sticking to the anterior capsule which I'll polish out. There is few cortex remaining and I'm attempting to perform polishing with a curved tipped coaxial handpiece. There is some cortex at the inferior part, but I am not able to remove it with this handpiece. Still, I am trying. The posterior capsule is also floppy. In white cataract, like Morgagnian cataract, the posterior capsule is highly mobile, which can lead to PCT. So I decided to perform polish and cortical removal with bimanual handpiece. Now I am introducing the bimanual handpiece and I am going to perform cortical removal and polishing of the anterior and posterior capsule. I always want the best result for my patient, best outcome. If you remove the cortex properly, there will be less chance of PCO development and less post-operative inflammation in the eye. You want a good polish and cortical removal so you can avoid all that problems. But in some areas of the capsule there is fibrosis which is not being removed even after mechanically rubbing it and performing polishing. It is not removing. but still I try and do my best for this patient. I think it is the best I can do in removing the cortex and polishing the capsule. Now I decide to refill the entire capsule with OVD and commence with the IOL loading in the cartridge for IOL implantation in the PC bag. Now I place the nozzle of the cartridge at the main port and attempt to inject the IOL into the PC bag, but I failed because the wound size was not increased. Now I again fill the anterior chamber with OVD, increase the wound size slightly to enable the nozzle of the cartridge to fit snugly. Now I again try to place the haptic inside the nozzle. I could not, so I placed the haptic and the nozzle through the wound. Now I am slowly pushing the IOL into the PC bag. I see that the leading haptic went inside the capsule. Then with the help of the spatula, I dialed in the tailing haptic inside the PC bag. Now only remaining part is removal of the OVD from the eye. Then the case will be completed. Thank you, my dear friends. Hope this video was helpful in developing your surgical skills.